Okay, let's dive into a topic that's incredibly relevant for revision, particularly if you're prepping for something like the MSRA exam, and honestly, crucial to recognize in practice, leukoplakia.
Mm-hmm.
You'll see white patches in the mouth quite often, but knowing what specifically makes a patch leukoplakia and why that distinction matters so much is key.
Yeah.
We've taken some comprehensive revision material, and we're going to distill it down for you, focusing on the absolute essentials.
That's right. Think of this deep dive as cutting through the noise to give you those high-impact facts you need.
Right.
To confidently identify this condition, understand its implications, and know the right steps to take. It's all about efficient, targeted knowledge framed for easy recall.
Okay, right then. Let's get straight into it. Leukoplakia. What exactly is it, like at its core?
Yeah, so at its core, leukoplakia basically means those white patches you might see, on the lining of the mouth. The mucous membranes.
Okay.
Seems simple enough, but, and this is really important, there's one critical thing about them.
And that crucial feature is?
That these patches are typically thickened, and most importantly, they cannot be scraped off.
Ah,
That inability to scrape it off is a defining characteristic. It's like the first thing you should think about when you see a white lesion. It immediately helps distinguish it from common things like, say, thrush, candidiasis.
which usually does scrape away.
Exactly. That usually does.
Okay, so thickened white patch doesn't scrape off. Got it. What else defines it?
Well, it has a very strong, well-established link to tobacco use, especially smoking. That's a big one. And this is vital. It's classified as a potentially pre-malignant condition.
Potentially pre-malignant. That sounds serious. That's the big worry here, isn't it? The risk of it turning cancerous.
Precisely. There's a risk it could become squamous cell carcinoma, which is, the most common type of oral cancer.
Right.
Now, the risk does vary quite a bit. One source might say around 1%, but another gives a much wider range, maybe 0.1% up to, well, even 17.5%.
Wow, that's a huge range.
It is. It tells you there are different factors influencing that risk, different types, maybe.
And you mentioned earlier it's defined by having no identifiable cause. What does that mean exactly?
Yeah, that's part of the clinical definition, really. It means after you've ruled out other known things that cause white patches, like the thrush we mentioned, or lichen planus, or maybe chemical burn.
Okay.
If you're left with this persistent, non-scrapable white patch, that's when you label it leukoplakia. And because of that uncertainty, a biopsy is almost always essential.
To confirm it.
To confirm it's not something else, and crucially, to check for those potentially cancerous changes that dysplasia will talk about.
Okay, so to sum up, persistent, thick, white patch, can't scrape it off, strongly linked to tobacco. It's kind of a diagnosis of exclusion in a way.
You could say that, yeah, after ruling out other specific causes.
And it's potentially precancerous, so biopsy is a must.
Exactly. Those are the fundamentals.
Okay, so if we know what it is, let's talk about why it happens. What causes it? What's the etiology?
Well, the exact single cause isn't fully pinned down. It's generally considered multifactorial.
Right.
But the evidence is just overwhelming that the number one risk factor, the biggest driver, is tobacco use. Smoking, smokeless tobacco, all forms.
Usual culprit, unfortunately.
Yep. Beyond tobacco, chronic irritation plays a major role.
Like physical irritation.
Yeah, think about things constantly rubbing or pressing on the lining of the mouth, like, sharp edges on teeth, or maybe poorly fitting dentures, even habits like cheek biting.
So repeated physical trauma, basically.
Essentially, yes, chronic mechanical stress. The revision material also lists other possible contributors or associations, things like certain types of HPV infection.
HPV as well, okay?
Yeah, and interestingly, connections with conditions like lichen planus, sometimes secondary syphilis, and even severe periodontitis have been noted.
Interesting how it can overlap. So who then is typically most likely to get leukoplakia? Who's most at risk?
Definitely. We touched on the big ones already. Top of the list is tobacco use, any form.
Right.
Excessive alcohol consumption is another significant one, and often they go together, unfortunately.
Right. Tobacco and alcohol, a notoriously bad combination for oral health.
Absolutely. They seem to have a synergistic effect, meaning the risk is much higher when they're combined.
Okay. What else?
Other factors include that chronic oral irritation we just discussed, and generally poor oral hygiene. Exposure to certain high-risk HPV strains is also implicated. Demographically speaking, it's more common in males than females.
What kind of ratio?
Typically around 2 to 1 males to females. And it usually affects older individuals, commonly appearing in their 60s and 70s.
Okay, so older men predominantly.
Yeah.
Let's try and bundle those risk factors. Tobacco, alcohol, chronic irritation, poor hygiene, maybe HPV, older age, male gender. Can we make that stick? How about a mnemonic?
Yeah, we could try one. Let's see. How about TAP IT?
TAP IT. Okay, break that down for us.
Right, so T for tobacco
Hmm.
and maybe trauma for that chronic irritation from teeth or dentures.
Okay, T for tobacco and trauma.
A for alcohol. Simple enough.
A for alcohol. Got it.
P could be for poor hygiene.
Yeah.
It maybe also include HPV and prolonged irritation there.
P for poor hygiene, HPV, prolonged irritation.
Okay, and for in males or increased age, or maybe individuals who are older males.
Let's go with in male solder individuals. TAP IT, tobacco trauma, alcohol, poor hygiene, HPV, prolonged irritation, in male solder. That works.
Covers the main bases, yeah. TAT, good one to file away.
Definitely. Okay, briefly then, what's happening underneath? The pathophysiology, what's the biology?
It's complex and, like we said, multifactorial, not fully understood. But the general idea, the proposed pathway, involves that chronic irritation, especially from tobacco smoke. This causes ongoing inflammation. Combine that with maybe some genetic predispositions, other environmental factors. It can lead to genetic mutations in the cells lining the mouth, the epithelial cells.
The cells actually change genetically.
Potentially, yes. These mutations mess with their normal growth patterns, how they differentiate. They might start multiplying too much or they don't mature properly.
Right.
And that leads to that buildup of abnormal thickened cells, which is what we see as the white patch.
And the link to cancer.
That's where dysplasia comes in. Dysplasia means abnormal cell changes that are visible under the microscope. It's like a step along the path towards cancer. If dysplasia occurs within the leukoplakia lesion, that's when the risk of it progressing to squamous cell carcinoma really increases.
Ah, okay. So dysplasia is that key warning sign in the cells themselves. That makes sense. Now, speaking of looking, you said earlier, lots of things can cause white patches. So when we see one, what else should be on our differential diagnosis list? What else could it be?
Yeah, this is really important clinically. Not every white patch is leukoplakia. Top of the list, always, is candidiasis thrush.
And the key there is?
It usually scrapes off. If you can gently wipe it away, leaving a maybe red, raw surface underneath, think thrush first.
Okay. What else?
Well, you need to consider things like chemical burns. Did the patient hold an aspirin against their gum? Inflammatory conditions like oral lichen planus can have white patches, often with a sort of lacy pattern. Lupus can sometimes affect the mouth, even psoriasis occasionally.
Okay.
And then there are rare benign genetic things like white sponge nevus. So quite a few possibilities.
It's a fair list. So how do you definitively sort through all that?
This really hammers home the point. While your history examination give you big clues, does it scrape off? What's the pattern? Smoker. Dentures. The biopsy and the histopathology report are essential. Gold standard. No question.
That's the decider.
Absolutely. It lets the pathologist look at the actual cells, confirm if it is leukoplakia, rule out the mimics, and crucially assess for that dysplasia. Mild, moderate, severe. That's key.
Okay, let's try a quick scenario then. Picture this. You see a white patch inside a patient's cheek. Heavy smoker. You try gently, doesn't scrape off. What's top of your mind? And how do you differentiate from, say, lichen planus, which also doesn't scrape?
Right. So heavy smoker, non-scrapable white patch. Leukoplakia is immediately very high on the suspicion list. But yeah, you'd still consider it lichen planus. Maybe lupus, less likely. Your next step, after carefully documenting everything, is arranging that biopsy.
No way around it.
No. The histology is what gives you the definitive answer. Is the cell structure consistent with leukoplakia? Is there dysplasia? Or does it look more like lichen planus under the microscope? That's how you tell.
Perfect sense. Biopsy clarifies. So how common is this condition? What's the epidemiology look like?
Well, estimates vary, but generally the prevalence is thought to be around 1 to 5% in the UK general population.
So not super rare. You're likely to see it.
Exactly. You need to be aware of it. And as we said with the risk factors, it mostly affects older adults. Peak incidence is sort of 60s and 70s.
Right.
And that definite male predominance, about 2 men for every 1 woman affected.
Okay, older men, most typical demographic. Let's zoom in on the clinical features. What does leukoplakia look like on examination? What are the variations?
Typically, it's a well-defined white or sometimes grayish patch or plaque. The texture can really vary, though. Sometimes it's smooth, almost like a thin layer of paint. Other times it can be quite irregular, maybe feel rough, or even have a sort of warty or pebbly appearance.
Warty.
Yeah.
That sounds different.
Yes, that appearance is often described using terms like verrucous or speckled. So the overall look can be homogeneous, meaning it's pretty uniform in color and texture.
Right, like one consistent patch.
Exactly. Or it can be non-homogeneous, which includes those speckled, verrucous, or even ulcerated types, more varied.
Okay, so from smooth and uniform to rough, speckled, warty, does it usually hurt?
Usually no. The patch itself is often asymptomatic. People might not even know it's there unless they happen to see it or feel it with their tongue.
But it's sometimes.
Sometimes, yeah. If it gets irritated maybe by food or rubbing it can become sore or cause a burning sensation.
But where does it typically show up? Common spots.
Yeah, very common on the buccal mucosa. That's the inside lining of the cheeks. Also the tongue, sides or underneath, and the floor of the mouth. But honestly, it can appear pretty much anywhere on the oral mucosa.
Okay. And the notes mentioned some kind of stages, how it might progress in appearance.
Yeah, it sort of describes a potential progression, clinically speaking. Stage 1 might be really subtle, just a faint, almost translucent white area. You might not even feel it.
Barely there.
Right. Stage 2 is more obvious, a definite opaque white plaque, maybe slightly raised, could be smaller, spread out, often with irregular edges.
Well.
Then stage 3 is the most developed clinically. It's thicker, might feel firm or hard to the touch, that's called induration, and you might start seeing cracks, fissures, or even small ulcers within the patch.
Those later stages, especially with hardness and ulcers, sound more worrying. Are there specific visual signs, specific clinical features that are like major red flags for a higher risk of malignancy? This feels like key MSRA stuff.
Absolutely. This is definitely high yield. You need to know these. There are indeed specific clinical features associated with a significantly higher risk of malignant transformation, things you should be actively looking for.
Okay, what are they? Lay them out for us.
Right. The non-homogeneous types, especially the verrucous or speckled appearance, that irregular warty look, that's a big one.
Okay, speckled, warty appearance.
Any erosion or actual ulceration within the white patch is a major red flag.
Ulceration, got it.
The presence of a nodule, like a distinct lump or bump within the lesion, also concerning.
Nodule.
And that hardness, that induration, either around the edge or within the lesion itself. If it feels firm or hard, that's a significant warning sign suggesting potential underlying change, like severe dysplasia or even early cancer.
So irregular speckled look, ulceration, nodule, hardness, induration, those are the clinical danger signs.
Precisely. And it's not just the look and feel, the location is also critical.
Where?
Lesions on the anterior floor of the mouth and the undersurface of the tongue are known to carry a higher risk of malignant change.
Floor of mouth, under the tongue, high-risk zones.
Exactly. Especially if you see those high-risk features there, like non-homogeneous appearance or induration, particularly in an older male patient, the risk climbs significantly.
That's a really important constellation of factors. Location, appearance, feel. Let's do another quick case. Let's say a 68-year-old man, smoker, comes in. You spot a white patch on the floor of his mouth. Gently palpating, it feels quite firm, and you notice a small, raw-looking area within it. Based on those red flags.
Yeah, that scenario ticks multiple high-risk boxes immediately. You've got the patient demographic, older male, the smoking history, the high-risk location, floor of mouth, and crucially, the clinical findings of both induration, firmness, and ulceration.
So the alarm bells are ringing.
Definitely. That picture strongly suggests a significantly increased risk of malignant transformation within that lesion. It demands urgent referral and biopsy.
That really helps cement those high-risk signs. Okay, investigations. We keep coming back to biopsy being key. Walk us through the overall diagnostic approach.
It always starts with a good clinical examination and a thorough history. Really dig into those risk factors, tobacco, alcohol, irritation sources. But yes, you're right. The biopsy is the absolute cornerstone. It's essential for diagnosis, for assessing risk, for guiding management. It's how you get definitive answers.
And what happens with that biopsy sample?
It goes for histopathological examination. A pathologist looks at the cells under the microscope. They confirm if it's leukoplakia, and most importantly, they determine the presence and the grade of any epithelial dysplasia. Is it mild, moderate, or severe? Or is there already carcinoma in situ or invasive cancer?
That grade of dysplasia is the crucial bit for risk assessment.
It's the most important factor, yes. It tells you about the malignant potential of that specific lesion.
Are any other investigations commonly used?
Sometimes endoscopy might be used, perhaps by the specialist, to get a better look at the extent or find suspicious areas, especially if cancer is strongly suspected. The notes also mention things like biomarkers, looking for genetic instability. These are more research tools at the moment. They can potentially predict risk, but they aren't standard practice for managing oral leukoplakia just yet. Gene mapping also has potential future value, apparently.
Got it. So history, exam, and definitely biopsy with histology. That's the core workup. So once you have that diagnosis,
Yeah.
how is leukoplaskia managed? What's the plan?
Right. First steps are always tackling those risk factors. Really push for smoking cessation, reducing alcohol intake.
And that make the patch go away?
Sometimes it can help, but the evidence on whether quitting alone causes regression is a bit mixed or questioned in some sources. Still, it's vital for overall health and reducing risk of new lesions or other cancers.
Makes sense. Address the cause.
Exactly. Beyond that, management is really about close monitoring and intervening if necessary. Regular follow-up is key, watching for any changes, size, color, texture, new symptoms.
And does that follow-up involve more biopsies?
Often, yes. Periodic rebiopsy might be needed, especially if the lesion changes clinically or if it showed dysplasia initially. You need to track what the cells are doing over time.
What about treating the patch itself? Getting rid of it?
There are options. Topical medications like retinoids exist, but the source material suggests pharmacological treatments generally have pretty limited effectiveness in eliminating the lesion or reliably preventing transformation.
So meds aren't usually the main fix.
Often not curative, no. The more definitive approaches involve physically removing the lesion.
Ow.
Things like surgical excision, cutting it out. Laser therapy is common. Certain lasers like ER, SIGAR-YSGG are mentioned as causing less tissue distortion, which can be helpful for histology later if needed. Cryotherapy, freezing it off, is another option.
And who makes these decisions? Who manages this?
This really should be managed by specialists. Referral to an oral and maxillofacial surgeon or an oral medicine specialist is standard practice. They have the expertise here. But it's really important to highlight something the sources emphasize. There's currently no universal consensus on the single best way to manage leukoplakia.
Really? No standard protocol?
Not a universally agreed one, no. And there's actually limited high-quality evidence proving that even removing the lesion guarantees prevention of malignant change down the line.
So even if you cut it out, cancer could still develop later?
There's still uncertainty about the subsequent risk, yes. And recurrence rates after treatment can be quite variable, too. It's a challenging area.
That really highlights the need for ongoing vigilance then. So what's the typical outcome? The prognosis? Does it always turn bad?
No, thankfully not. The prognosis is really variable. It depends heavily on those factors we've discussed. Presence and grade of dysplasia on biopsy, the size and location, whether risk factors are stopped.
And what happens in most cases?
The good news is most cases actually remain stable. They just sit there, don't develop significant dysplasia, don't progress to cancer.
Okay, that's reassuring.
But it's that subset that does progress to squamous cell carcinoma that drives all the surveillance. Progression rates are often cited somewhere between, say, 1% and maybe up to 9% in various studies.
Are there specific things that make progression more likely?
Yes, a couple of interesting points here. Remember we said males are more likely to get leukoplakia?
Yeah, 2.1 ratio.
Well, interestingly, the notes suggest that female gender might be associated with a slightly higher risk of progression to cancer once the lesion is actually present.
Huh. Okay. That's counterintuitive.
It is a bit. Continued smoking, obviously, increases progression risk. And those non-homogeneous types, the speckled, the verrucous ones, they consistently carry a higher malignant potential.
Makes sense. They look angrier.
Pretty much. It's also noted that while dysplastic lesions can sometimes regress on their own, they can also carry a worse prognosis than even some very early isolated cancers.
Wow.
So the takeaway is it's variable. Surveillance is crucial, but even with follow-up, the outcome isn't always predictable, partly because management isn't perfectly standardized.
So wrapping up, what's the main potential problem, the main complication we worry about with leukoplakia?
The number one concern, the driving force behind all the monitoring and management, is that potential for malignant transformation into squamous cell carcinoma. That's the big complication.
And catching it early is key.
Absolutely. Identifying dysplasia or early malignant changes during follow-up is critical because intervening at that earlier stage gives the best chance for a good prognosis.
Are there any other complications besides the cancer risk?
Well, beyond that major concern, the lesion itself can sometimes cause chronic irritation or discomfort. Depending on size and location, it might interfere with eating or speaking. And of course, there can be a psychological impact knowing you have this lesion that needs watching, that has this potential risk.
Understandable. Well, that gives us a really solid, comprehensive overview of leukoplakia. Really useful.
Yeah, it covers those essential points you really need to grasp for revision and for clinical practice.
So, key takeaways for your MSRA revision. Leukoplakia
Yeah.
is that non-scrapable white patch, think tobacco link, diagnosis of exclusion, and crucially, potentially pre-malignant. Lock down those risk factors. Remember TAP-IT. Know that biopsy and histology are absolutely essential for diagnosis and checking for dysplasia.
Definitely.
Be super aware of those clinical red flags for high risk. Speckled warty look, ulceration, nodules, hardness, especially on the floor of mouth or under the tongue.
Spot on.
And understand that while most cases are stable, that risk of malignant change means long-term surveillance is vital, even if management protocols aren't set in stone.
Recognizing those features, understanding the implications, it's a really important clinical skill.
Absolutely. Getting comfortable with these key facts puts you in a strong position.
Okay.
Fantastic. For more free MSRA revision resources, visit freemsra.com, and for the full premium revision toolkit, head to passthemsra.com.
Great resources there.
Thanks for joining us for this deep dive into leukoplakia. We hope this focused session helps clarify those essential points for you. Join us next time for another deep dive.